board meeting. My name is Joanne Pacheco, and I am the president of the board. Today is Thursday, May 13th, 2021. This board meeting is being held via WebEx. Pursuant to the provisions of Governor Newsom's Executive Order N29-20, dated March 17, 2020, neither a public location nor teleconference locations are provided for this meeting. For all those who wish to participate, please log on to the WebEx website provided on the posted agenda for this meeting. Instructions to connect to the meeting are provided on the agenda. The preferred audio connection is via telephone conference and not the microphone and speakers on your computer. The phone number and access code will be provided as part of your connection to the meeting. Since this meeting is being conducted via WebEx, I will ask all board members and speakers to announce themselves by name before speaking for clarity of the official record. All board members are able to unmute themselves to speak during the meeting. Please place yourself back on mute when not speaking to reduce background noise for all participants. When making a motion, please use the raised hand feature located at the bottom right of the WebEx screen so board staff can identify a motion and a second. During a discussion on an agenda item, please use the raised hand feature if you want to speak, and I will call on you. Following such online meeting etiquette will ensure the best audio quality for everyone. During each call for comments from the board members and speakers, we will ensure that all comments that can be accommodated are heard before proceeding with the agenda. This is an official business meeting of the Dental Board of California. The board welcomes public comments on any item on the agenda, and it is the board's intent to ask for public comments prior to the board taking action on any agenda item. The DCA moderator will explain the process for providing public comment shortly. When called upon, the moderator will unmute the microphone of the individual and they will have 2 minutes to make a public comment. After the 2 minutes have lapsed, the individual will be placed back on mute. Only one public comment per agenda item is allowed per attendee. Depending on the number of people who would like to testify on a particular agenda item, a total time limit may be imposed. We ask all speakers to stay on topic and not repeat testimony already provided. If you agree with testimony already provided, please just state your name and that you are in support of any comments previously provided. I would now like to ask the DCA moderator to please explain how public comments will be taken during this WebEx meeting.
Good afternoon, this is the moderator. To facilitate public comment today, we will be utilizing the WebEx question and answer feature. When the board reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on, and members of the public can indicate they would like to make a comment by inserting the phrase, "I would like to make a comment," into the question box, which is typically located in the lower right hand of your screen. At that time, I'll also display these instructions, and in order to access that comment box, you will be looking for the Q&A icon on your screen, which is a question mark inside of a square, and clicking on that will activate that question box for you. I will then call on the individuals in order that the comments requests are submitted. Each individual will have 2 minutes to make their comments, as mentioned by President Pacheco. And at the conclusion of the 2 minutes, I will provide a reminder, and then the individual's microphone will be muted. And at that point, we will move on to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for the members of the public to represent that they would like to make a verbal comment. This is not a means to ask questions of the moderator or members of the board. Such inquiries submitted using this feature will not be answered. When making your comment, please make sure the comment is directed at the host in the drop-down. While you are free to express criticism or negative views, for the sake of the members of the public participating on the call, please do not use profane language when making public comments to the board. I will provide a brief reminder of this approach at the start of each public comment item. And when board members and senior staff are not speaking, I would like to remind them to mute their microphones to reduce background noise. If I do detect a microphone unmuted that is creating background noise, I will interject with a brief friendly reminder to mute your microphone, or if the moment is not opportune at that time, I may mute your microphone myself. So just as a reminder, before you begin to speak, make sure you unmute your microphone, and that would be so that you can see the green microphone on your option button, and that will tell you that your microphone is open. And again, just as a brief reminder, I did have a question before the meeting started for our panel members. For the raised hand feature, if you have your participant panel open, where you can see all of the participants on the right side of your screen, at the very bottom of that participant list, you should see a very small icon of a hand. That is what you will want to click on if you would like to raise your hand, and then clicking on it again will lower your hand. And with that, I will turn the meeting back over to President Pacheco.
Thank you, DCA moderator. I would like to call the meeting to order and ask the board secretary to please call the roll.
Good afternoon. This is Dr. Alan Felsenfeld, board secretary. I will now call the roll. Burton.
Here.
Burton present. Chan.
Present.
Chan present. Felsenfeld present. Laureen.
Present.
Laureen present. McKenzie.
McKenzie present.
McKenzie present. Medina.
Present.
Medina present. Mendoza.
Present.
Mendoza present. Molina.
Molina present.
Molina present. Montel.
Montel present.
Montel present. Morrow.
Morrow present.
Morrow present. Alagi.
Olagi present.
Alagi present. Pacheco.
Pacheco present.
Pacheco present. Stewart.
Stewart present.
Stewart present. Yu. Dr. Yu.
This is the moderator. Do you see that he is still connected? Dr. Yu, your microphone is muted.
You check my mic already.
Dr. Yu.
I'm here.
Thank you, Dr. Yu. Madam
Okay.
President, we have a quorum.
Thank you, Doctor. We will now move on to agenda item 2, discussion and possible action on February 25th, 2021 and February 26th, 2021 board meeting minutes. Is there any board member discussion? Please use the raised hand feature. Seeing none, is there a motion and a second? Please use the raised hand feature for a motion and a second.
You motion.
You motion and Medina second. Thank you. So motion is to accept the minutes as written. You motion and Medina second. Are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We have opened the Q&A panel for requests for public comment. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text box and submit that to the hosts. And not seeing any requests, would you like me to close the Q&A panel?
Yes, please. And thank you. Board Secretary, please call the roll and record the votes for the agenda item.
We're out voting on the motion to approve the minutes of the February 25th, 26th, 2021 meeting. Burton. Ms. Burton?
This is the moderator. Member Burton, you are muted.
I'll continue down. We'll come back to her in just a few moments. Dr. Chan,
Abstain.
abstain. Chan, abstain. Felsenfeld, aye. Loreen,
Noreen, aye.
Loreen, aye. Mackenzie,
Mackenzie, yes.
Mackenzie, aye. Medina,
Yes.
Medina, yes. I'm sorry, did you say something? Medina, yes. Mendoza,
Aye.
Mendoza, aye. Molina,
Aye.
Molina, aye. Montel,
Aye.
Montel, aye. Morrow,
Morrow, aye.
Morrow, aye. Olagi,
Olagi, aye.
Olagi, aye. Pacheco,
Pacheco, aye.
Pacheco, aye. Stewart,
Stewart, aye.
Stewart, aye. You,
Aye.
you, aye. Miss Burton, can you hear us? Miss Burton? Moderator, do we have her still on?
She is still connected. Member Burton, your microphone is muted. If you could please unmute your microphone. We may need staff to reach out to her. And Dr. Yu, your hand is raised. Did you have a question? If not, if you could please lower your hand.
Okay, sorry about that.
Madam President, we have 12 ayes, 1 abstention, and 1 absent at this point. The motion is approved.
Thank you. We will now move on to agenda item 3, Board President Report. So as I was preparing for my report today, I reflected on how much I miss seeing all of you in person. And at the same time, I'm grateful that we're able to meet in the virtual environment. I would like to thank the board's executive officer and all of the board staff for their continued diligence maintaining board operations during the pandemic. At this time, I would like to congratulate Dr. Chan, Dr. Laren, Ms. Olagi, and myself on the reappointments to serve on the Dental Board of California. In carrying out my duties as board president, I continue to meet with the executive officer on a weekly basis, and I attended the Dental Hygiene Board of California meetings on March the 6th and March the 20th, and the Dental Assisting Council meeting on April 30th. As we move through our agenda today, let us be reminded that the members of the Dental Board, individually and collectively, are dedicated to the legislative mandate that protection of the public shall be its highest priority. Whenever the protection of the public is inconsistent with other interests sought to be promoted, the protection of the public will always be paramount. This concludes my report, and we will now move on to the next agenda item. Are there any board member comments? Please use the raised hand feature. Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. I have opened the Q&A panel. If you'd like to make a comment on this item, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text box and submit that to the hosts. Not seeing any requests, would you like me to close the panel?
Yes, thank you. We will now move on to agenda item number 4, Executive Officer's Report.
Thank you, President Pacheco. This is Karen Fisher, your executive officer. I'd also like to congratulate the members that were reappointed, Ms. Olagi, Ms. Pacheco, and Dr. Laren, and welcome back, Dr. Chan. We are glad you are among us again. I wanted to just report briefly on the strategic plan update. Thank you, board members. Tricia Sinclair, who is working with us from Solid, has indicated that everybody gets a gold star because they responded to her request for an interview very quickly, and she's gathering important information about the strengths and weaknesses of the board. She will be putting that information together into a report that eventually the board will be seeing and discussing. The next step is that she has created a survey which will go out to stakeholders and licensees. We anticipate that that will go out next week, asking them for their input on our strategic plan also. After that information is gathered, everything will be compiled, and we will be trying to set an in-person meeting of the board, probably sometime in September, to actually develop the strategic plan. And essentially what we're working toward is the board actually adopting its plan at the November meeting. Staff is also preparing for the end of the state of emergency in California as counties continue to move up in the colored zone and the restrictions are eased. We are anticipating that the waivers will end and we will be able to go back to in-person meetings. So staff has reserved hotel space for the August meeting and for the November meeting in Sacramento. So we will be able to pivot if and when the state of emergency is lifted. On that note, I wanted to let you know that usually at the August meeting, board members determine what the meeting calendars will be for the next 2 years. So for the August meeting, please bring your calendars. Staff will start to put recommended dates out there, and we'll just start to essentially establish the meeting dates for 2022 and 2023 at the August meeting. I wanted to indicate that you all should have received a new copy of your Dental Practice Act. Everything that we do is in that book, essentially. So it's comprised of the Business and Professions Code, which allows the board the authority to conduct its business, as well as Title 16 California Code of Regulations. And lastly, I just want to thank the board for your responding to the discipline votes that we sent out. Yesterday, staff sent out 5 cases for your review. We have scheduled the votes to be back by May 24th, which essentially allows you 2 weekends to go ahead and review the discipline and to vote on that. And I appreciate your attention to that as soon as you can get to it. And that concludes my report for today.
Thank you, Ms. Fisher. Are there any board member comments? Please use the raised hand feature. Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. I have opened the Q&A panel. If you'd like to make a comment on this item, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and then submit that to all panelists. Or actually, the host. And seeing no requests, would you like me to close the panel?
Thank you. We will now move on to the examination committee meeting. We will now recess the meeting of the full board, and the examination committee will convene, chaired by Dr. Stephen Morrow, who will facilitate this meeting. Will the moderators please move all board members who are not on the committee to the attendees list?
This is the moderator, and I am moving members not on the exam committee to the attendees list. You'll give me just a moment. Okay, they have all been moved, and I will bring our presenters up to our panelist list. All right, our presenters are with us in the panelist list, and I have activated the cameras for them to utilize. And I apologize, was that Dr. Morrow that was chairing this committee?
Yes, yes,
Yes.
are we
Dr.
ready?
We are ready. The floor is yours.
Okay, good. Thank you very much. I appreciate it. And I would like to call the examination committee meeting to order and ask board staff to please call the roll.
This is Kahua Tao, the administrative analyst, and I will now call the roll. Felsenfeld,
Here.
Felsenfeld present. Laren,
Aaron, present.
Laren present. Molina,
Molina, present.
Molina present. Morrow,
Morrow present.
Morrow present. Olagi,
Olagi present.
Olagi present. Stewart,
Stewart present.
Stewart present. And a quorum has been established.
Thank you very much. We will now move on to agenda item number 2, public comments on items not on the agenda. Are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. I have opened the Q&A panel. If you'd like to make any public comments on items that are not on the agenda, please click on the Q&A icon on your screen, type, "I would like to make a comment" into the text box, and submit that to the host.
Seeing as how there are none.
Seeing none, I will close the
we'll
panel.
move- Good, thank you. We'll now move on then to agenda item number 3, discussion and possible action on the February 23, 2017 examination committee meeting minutes. Normally, members are advised to abstain from voting on meeting minutes of a meeting the members did not attend. Since I am the only sitting member for the February 23, 2017 meeting, I propose to approve the meeting minutes without a motion to adopt. Are there any committee members' objections or discussion? Please use the raise hand feature.
Dr.
Seeing as
Morrow,
how
I see
there-
Dr. Felsenfeld.
I'm sorry, I didn't see a
I see-
hand. I'm sorry. Dr.
Yeah, I see
Felsenfeld.
Dr. Felsenfeld. Yeah, and then Dr. Molina also went up.
Okay,
Dr.
thank you.
Felsenfeld, Dr. Morrow, tell me again, what is it you're trying to do here? I'm not sure. You said approve it, but not pass them, or what was it you're asking us to look at?
Right. Well, my understanding is that because I'm the only member that was part of the committee when this meeting took place and these minutes were recorded, that it's impossible to have a motion and a second because I would be the only one that could move and second. So my understanding is that the committee can move to approve the minutes without a motion to adopt.
Okay, I'm just as confused as when we started because I don't know that that's really possible. I suspect you could just file the minutes away. They exist. No one can approve them. I guess we could vote to approve them, But since we haven't been there, I would be uncomfortable. I was going to abstain, certainly, so not sure where to go with that.
Okay.
This is
My
Tara Welch,
understanding is-
Board Counsel.
Okay.
I just wanted to step in and explain this a little bit. Pursuant to Robert's rules, for meeting minutes, you can just approve the meeting minutes. That way we can get them posted online because the committee has reviewed them. But because Dr. Marr is the only member from 2017, you would not want to take a motion to approve the meeting minutes like you would normally do because all of the other 5 members typically would abstain from that motion. So we're just suggesting that Dr. Morrow approve the meeting minutes, and that's it. No motion. Does that help?
Dr. Morrow,
Alan,
this is
does that help
Karen,
you?
and Dr. Molina has her hand up too.
Okay, Dr. Molina.
I just have a question. I noticed that on the minutes of February 2017, on page 2, it says that the committee concluded that the electronic submission for the pathway can be discussed at a future meeting for consideration. So since we're not meeting until 2 years later, what happens when there are items that are pending? Do we wait for until the next meeting?
Yeah, my opinion in that respect, but and will maybe legal can help us out here. My opinion is that those pending. It was 4 years ago that this last committee met, so pretty much outdated in whatever was discussed at that time. But reviewing the minutes, we would have to take a look and see if there were any issues that need to be readdressed at a future examination committee meeting.
Thank you.
Any other comments or questions?
Dr. Morrow, you still have your hand up, as does Dr. Molina. If you could put your hands down, that'd be great. Thank you.
I just did. Thank you. Okay. So at this point in time, I'm going to ask, is there a motion and a second to simply approve the meeting minutes? And please use the raised hand feature for a motion and a second.
This is Board Counsel, Tara Welch. The whole point of you just approving the meeting minutes was to avoid a motion to adopt the meeting minutes because
Okay. All right.
we would normally have everyone who wasn't at that meeting abstain. So effectively, if there's no objection to you approving the meeting minutes, then I would
Okay.
recommend you go to public comment.
All right. Thank you very much. Is there any objection to me approving the minutes? If so, use the raised hand feature. Seeing none at this point, we'll move to a public comment. CCA moderator, would you please facilitate the line for public comment?
This is the moderator. I have opened the Q&A feature within WebEx. If you'd like to make a public comment on this item, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to the host. Okay, seeing no requests, would you like me to close the panel?
Yes, please. Thank you. Okay, thank you. We will now move on to agenda item number 4, discussion and possible action regarding the American Dental Association Dental Licensure Objective structured clinical examination. I requested a meeting of the examination committee to discuss the ADA Delaski as a possible pathway to licensure in California. Representatives are here from the commission are with us here from the Commission on National Dental Examinations to provide information to the committee. I would like to welcome Dr. Michael Sanders, Vice Chair of the Joint Commission on National Dental Examinations, Dr. David Karsten, member of the Steering Committee for the Dental Licensure Objective Structured Clinical Examination, and Dr. David Walschmidt, Director of Testing Services Department for the Joint Commission on National Dental Examination, to provide a presentation to the committee. Dr. Sanders, Dr. Karsten, and Walschmidt, I turn over the next 2 minutes to your presentation.
This is Dr. David Waldschmidt, Director of the Joint Commission on National Dental Examinations. Thank you so much, Dr. Moreau. It's an honor to have this opportunity to present before the committee today. We're very pleased to be able to share information about the Joint Commission on National Dental Examinations, Dental Licensure Objective Structured Clinical Examination, also known as the DLOSCI. The first thing that I want to do in this meeting is to reach out and thank board members for all their work in protecting the public health. I realize it's a thankless job with a tremendous amount of commitment required and a lot of work, and it can be certainly thankless work. And certainly as a father of 4 children, I can really appreciate your efforts. And also in speaking about the examination and speaking about the board's duties, the committee's duties with regard to protecting the public health, that is certainly a core belief and a core value that all of us held dear in working with the Dental Licensure OSCE. I'm fortunate to be here today, if we could advance to the next slide, with Dr. Michael Sanders and Dr. David Karsten. I'm humbled and privileged, really, to be able to work with these individuals. Dr. Sanders, as was indicated, is the Vice Chair of the Joint Commission. He is also a former member of the Nevada State Board of Dental Examiners, former examiner for CDCA and REB, emeritus professor for the University of Nevada, Las Vegas School of Dental Medicine, and also a past president of the Nevada Dental Association. And also Dr. David Karsten, who is the vice chair of the Washington State Dental Commission, soon to be chair, I believe, in about a month or so, a faculty member at Oregon Health and Sciences University, and founding member of the DLOSCI Steering Committee, whose insights really throughout the entire process were invaluable to the committee in the development of the examination. As well, I could note a personal debt of thanks to Dr. Karsten. At the beginning of this whole pandemic, he had a series of webinars that he offered online that were just tremendously helpful to me and my family, and as we approached the pandemic and informing us as best we could at that period of time. And so with regard to the conversation that we're all about to have about the DLOSCI and the information we're going to share, please feel free to ask questions at any time. I know what it's like to sit in a presentation and to have a burning question on your mind that you want answered, and to have people keep going and you can't even pay attention because you're thinking about that question that's really at the forefront of your mind. So please feel free to ask questions. We're happy to entertain them as we go. So without further ado, if we can go ahead and go to the next slide. So in terms of what we'll be talking about today, first, we'll be talking about some just general considerations in choosing licensure exams. How should you go about, what are considerations for boards as they think about the criteria for evaluating such examinations? We've got some ideas here before you. We'll provide some background and history of development of the DLOSCI. We'll talk about the specific approach that we utilized. We'll talk about the content areas, how questions are formatted. We'll talk about the lifelike 3D models that we've developed to facilitate measurement of candidate clinical skills. We'll discuss some key questions that often arise when we talk about the DLOSCI and its development, and some key decisions that were made by the DLOSCI Steering Committee. We'll talk about validity evidence for current clinical licensure examinations, as well as some evidence for the DLOSCI and findings there. And then we'll provide a summary and go to Q&A and provide some additional information and resources for you. Next slide, please. And so this is a key question, I'm sure, that's on everyone's minds at this point. How should dental boards choose licensure exams? And I think at this point, I'll turn it over for a moment to Dr. Sanders, if Dr. Sanders would like to comment on some of the information on this slide.
Thank you, David. I don't know how well the video is coming in of me, but when we begin to look at licensure examinations, I have had the joy of participating as an examiner for a couple of regional boards and sitting on the board of examiners. And the first question that everyone always asks, and the charges that appear for state boards, is to protect the public. One of the things I've always found interesting as I examined for a regional board is they would always show some catastrophic performance by a candidate on a tooth on a board and say, look at this, how can this possibly protect the public? And the issue I have with that is I don't have a problem showing that, but I think you need to understand why those things show up in examinations. And primarily our position is, and my personal one from a 40-year academic career, is it shows up because the individual who is sitting for the examination is not prepared with a knowledge base in their own mind to be able to deliver that knowledge base to their hands to do a satisfactory performance on an examination. So it's a lack of judgment by the candidate, not necessarily a lack of skills. And if you look after examinations are analyzed as we go forward, frequently most of these candidates can come back again and do a satisfactory performance on a clinical examination. So when you begin to look at, say, as an examination, be it a patient-based or a non-patient based, is the exam valid and reliable? It really is looking at testing that candidate's ability to make an appropriate clinical decision. So I think that's one of the things that we look at the Dulosky as a really great instrument to do that, because it standardizes the playing platform for the candidate taking the exam. There is no risk of the patient not showing up. There is no risk of the tooth blowing up during a procedure, which I had happen when I was grading a board. I think this ability to sort of standardize the platform upon which assessment is based is extremely important to sit and say your exam is valid and reliable. For me, that goes hand in hand with item 3, the exam treat candidates fairly. I do think there routinely are complaints about patients. I know when I took my board in 70 something, there was always the sense of there being no fairness in the board, and there were certain random things that occurred during the board, which neither examiners nor patients nor candidates could control. So the next point that we usually get at is looking at our exam, is it fair? And basically the responses from those who took the exam felt it was fair so far, and the issues of having a standardized platform and appropriate professional content has made it a very fair examination for the candidate. I do think if you want to ask the question about candidates' knowledge, skills, and abilities, that really is the key issue of clinical judgment. Clinical judgment is what the Dulosky is measuring. It is a clinical exam. It is an exam that is very heavily based in all the aspects of clinical care and requires a very solid foundation to do well on the examination in clinical sciences. Perhaps I'll let Dr. Carson, you want to talk about the issue of the development of the examination?
Well, I think I'd like to back up a little bit and tell people why I got involved at all. I was listening to the then incoming ASDA president, who was going to become ASDA president, Dr. Suleiman from the University of Washington, and he spoke at the Washington State House of Delegates meeting, and talking about how unfair live patient exams were and some of the alternatives, and I can relate. Although I did freezingly well on the Washington State licensure exam that I took in 1984, and the later REB exam that I took because I wanted licensure in Oregon, I saw a lot of people that I thought should have passed, not pass, and people that shouldn't have passed, pass in these live patients exams. There was this element of randomness, of patients not showing up, or even the horrible circumstance of the students being shaken down by a patient saying they're not going to show up unless they were given $1,000 or whatever the circumstance. So because of that, well, I listened to him talk and I went into mentor mode because I teach at Oregon Health Sciences University in hospital dentistry, and talked about how he could be more effective. But I also listened to what he had to say about the OSCE in particular, as he was talking about uh, why it works so well in Canada. So I started to investigate, why is this really a viable approach? And I saw that Canada had been doing it for more than 20 years. They started doing OSCE examinations because they didn't want to get into doing live patient exams. They did it because of NAFTA. They needed to have some kind of examination. Before that, they trusted their schools to produce candidates. So it got me to thinking and literature, what makes a doctor in a healthcare context? Critical thinking, clinical judgment, and Hippocratic ethics and morality, as well as that minimal competence in clinical procedures. And then when I think about as a commission member in Washington State, what do I actually see when I do discipline cases? And at this point, I've done many, and usually it's critical thinking, clinical judgment, and ethics. And it's actually fairly rare that somebody can't cut a class 2 composite preparation. So my concern with these boards further is that with the live patient boards, they're encouraging what I certainly see as unethical behavior, where we're doing things that are no longer considered appropriate. We're asking students to do that, to find these board indications. We're asking them to delay treatment. People are brought in from out of state. There may be limited means of following up on these patients. And just the cynical attitude that I see the students taking with this kind of approach. And I continue to hear this from pre-doctoral students, but I also wanted to state that because we've had 2 rounds of students at Oregon Health Sciences University take the DLOSCE, that I've been impressed at the comments that I get, how they will tell me that, wow, that was really difficult, but it was very fair, and that it tested my whole career as well as it tested all aspects of dentistry. And they have great appreciation for that. Further, I've been able to, at the school, engage in training faculty to make OSCE exams, and I think Dr. Waldschmidt can appreciate how difficult that is, because it's such a different way of thinking, to think on a different level than simply regurgitation of facts. So I'm going to turn this back to Dr. Saunders for added comments from the JCNDE's perspective.
Yes, thank you very much. I always appreciate your comments, and certainly have lived through many of the same ones that you were dealing with. I think when we begin to look at examinations, I think one of the things is absolutely necessary is having a foundational knowledge for how to structure an examination. And there is art and science in the construct of examinations that often is a little bit beyond the dental realm in my expertise. And so we begin to look at how do we blend our dental subject matter experts with psychometricians to begin to develop an examination that meets our criteria and is valid and reliable. I think it is probably worthwhile to turn it over to Dr. Waldschmidt at this point, who I think will give us a little bit about testing and the science of testing.
Thank you, Dr. Sanders and Dr. Karsten. And that's exactly what I'll do now. And so my background is in industrial organizational psychology. And so when you see on this screen questions about, is the exam valid and reliable? Does the exam treat candidates fairly? You know, those questions of validity, it harkens to that bottom bullet point. What is the evidence that's available that supports the use of your exam for its intended purpose is key. It's a critical aspect. And the concept of treating candidates fairly is interwoven with that concept of evidence and validity, because How can your exam be valid if it doesn't give candidates a reasonable opportunity to demonstrate their skill? If the exam doesn't accurately reflect candidates' knowledge, skills, and abilities. So all those are interwoven together, and the concept of reliability is freedom from sources of measurement error, random sources of measurement error. You want your exam to be as precise as possible. These are critical decisions that are being made, and you want to make sure that you're making the right decision. Candidates who have the skills, you want to move forward. Candidates that don't have the necessary skills to safely protect the public should not move forward. And so those are all incredibly critical. If I can ask that we advance to the next slide, please. So as we think about these decisions from a psychometric perspective, our key reference is the Standards for Educational and Psychological Testing. It's a book you can't probably see it on my screen, but keep it close to the desk really at all times. Put up by the American Educational Research Association, the American Psychological Association, and the National Council on Measurement and Education to provide guidance on how to build strong, valid, reliable, rigorous examinations that fulfill their intended purposes. And we take that information and also best practices as we went to build the Dulosky to make it an effective examination that was capable of protecting the public health and doing a great job at it. Next slide, please. And so here, again, this comes from the Standards for Educational and Psychological Testing. For all intents and purposes, on the first page, really, after the foreword, giving you that definition of validity, the degree to which evidence and theory supports interpretations of scores or their proposed uses. And just below that, evidence of that validity is a necessary condition for the justifiable use of the test. What are the consequences if an exam lacks validity? Well, those who lack the skills can pass and go on to practice, assuming that they meet the other criteria from the board. Those who possess the necessary level skills may fail the exam, and at minimum, their careers can be delayed in helping to protect the public health, deprives a qualified individual of their license. In both cases, the public is not protected. Next slide, please. So why develop a Dulosky? It's funny, at the beginning of this process, the phrase we sometimes heard was, "You're about to start World War III." It was really to give dental boards the ability to identify those who lack the skills that are necessary for safe practice using a professionally developed exam to eliminate some of those undesirable situations that Dr. Sanders and Dr. Karsten described, provide objective, comprehensive measurement of candidate skills, and really to help boards in their mission to protect the public. Next slide.
Fortunately, I've taken the Washington Commission through some of that already in the approval of using the Canadian board, their OSCE. And so I think that's why I got asked to be on the steering committee. Or you could illuminate that more for me if you wanted to, Dr. Waldschmidt.
I can't speak to the specific factors. All I can say is that I'm quite thrilled that they did, because I appreciate
I would just like to say very specifically that I was opposed to you in the beginning of this activity.
Oh, really?
The reality was, as a wet finger hands-on dentist who graded examinations, I didn't know what this was about. I didn't understand the science behind it. That was the part that won me, was as a clinician to sit back and look at the educational, psychological, and clinical sciences, how they came together in an exam that is really challenging, comprehensive, and valid. So I did change my mind.
Mike, it took me over a year of study to figure out what this was really about, looking into the medical and other literature that I should have just waited to meet Dr. Waldschmidt. It would have taken me a lot less time.
Well, it's funny. It's funny, as we were presenting to the committee here, that all three of us, I think, were skeptics at the start and have really changed completely our perspective. I also had questions, in the notion of hand skills. But as I've worked with this examination, as I've worked with the dental subject matter experts on the Dulosky Steering Committee, over 150 subject matter experts who built the content for the examination, as I've looked at the core issues, as I've looked at the research that's available, it completely makes sense to me, and I shifted my opinion as well. And this is, for me, the way to go. This is the way, my understanding, a strong, valid, reliable exam to protect the public health to fill this clinical licensure requirement.
It's the way the rest of healthcare does these kinds of tests.
Exactly. And that's when we talk about why conduct specifically an OSCE. What OSCEs are essentially their methods of measurement. And each particular method of measurement can be very strong at measuring certain things and could be very poor at measuring other things. For example, if you were conducting an interview, that's going to do a great job for you in terms of understanding someone's oral expression skills and perhaps a little bit about their oral comprehension skills. But in terms of understanding their written expression skills, it won't work at all. And so with the OSCE and with the OSCE approach, it's a method of measurement that really is great at assessing clinical skills, theoretical knowledge, a broad range of skills. And for that reason, it's widely used in the health sciences. It's standardized. There's strong validity evidence that can be brought to bear. It's reliable. It's fair. It gives the candidates the opportunity to demonstrate their skills. Next slide, please. And so here, the Dulosky approach, assessing those, the focus of the Dulosky is on the tasks that a dentist performs while providing direct chair-side treatment to patients. It's assessing quality, depth, and breadth of clinical judgment, higher order processes. When Dr. Karsten's talking about critical thinking in dentistry. And Dr. Karsten, I've heard you say, does the person think like a doctor?
That's right. That's what I determine as an attending in hospital dentistry, is I have to make sure that they think like a doctor, because we treat people with multiple comorbidities that may be terminally or close to terminally ill. So they have to think with that critical thinking. It's just a non-negotiable.
Yep. And so through the Dulosky, providing that professionally developed psychometrically valid tool. And when we talk about evidence that supports the exam use, part of it deals with the process that was used to develop content for the Dulosky and the expertise that was involved. And here, as I mentioned, 150 teams of highly qualified subject matter experts, over 150 test instructors who are practicing and or academic dentists, and also with reviews by general dentists to make sure that you're not assessing trivial content that might be interesting but more esoteric. This is hands-on, really important skills. The day-to-day, the bread and butter of the work of a general dentist is what's covered here. Builds upon the well-established understanding of OSCEs as they were practiced, as was mentioned in Canada with the National Dental Examining Board of Canada, and all the evidence that has been accumulated through the work of Dr. Jack Giroux, former executive director of NDEB Canada, in supporting the exam. And in fact, we enlisted Dr. Giroux in our development of the Dulosky. He served as a technical advisor and was there through the whole process, right up to the release time. And I know he was quite thrilled when he saw it in action in terms of being able to work with the 3D models and those kinds of things in a live administration of the exam.
After all that work, it brought a tear to my eye to really see those statistics you had to provide us with, Dave. It was remarkable.
Yeah. And we'll get to share some of those in a little bit here. Next slide. And so in terms of the areas that are covered by the Dulosky, this gives you a sense of the topic areas and how items are allocated across those areas. You can see the largest portion, restorative dentistry, then PROS, oral path pain management and temporomandibular dysfunction, perio, oral surgery, endo, ortho, medical emergencies, prescriptions. Of course, across all those areas, diagnosis and treatment planning are critical. Occlusion is in there as well, involving patients with a wide variety of backgrounds, pediatric, geriatric, special needs, medically complex. And all of these questions and scenarios that are presented to candidates are representing real dental clinical situations. Next slide, please. So as a candidate faces questions that appear on the Dulosky, each question, there's multiple ways that it can be evaluated. One is you have a question that poses obviously a question to the candidate, and various response options. There can be a large number of response options, 12 response options, for example. Some of those response options can be correct. Can be more than one can be correct. You can get partial credit. Some of those response options can represent clinical judgment errors, incorrect response options. And if you choose those, even if you chose some correct answers, you get no point, no credit at all for that question. Then there are going to be some other options as well that are unscored or can be. There are other options as well that can be unscored or neutral. And that can be more of an indeterminate situation where, for example, two dental subject matter experts might have disagreed about what a correct response might be, or there might be some ambiguity. So scored in various ways, each item on the exam. Next slide, please. And here's an example of a patient box. You can see, and one of the things when I talk about fairness, there's not a heavy language component to this. It's very concise and very direct, providing information about the candidate, their chief complaint, their background and or patient history, and what the dentist's current findings are. And so I invite you to take a look at this slide here.
You know, I'd like to mention that one of the things that the Canadians impressed upon me when I was working with them, looking at the OSCE that they did, is that it's very important to not make it tricky. We don't want to make a deceptive question, but it was important to test depth of knowledge.
Exactly. You want each question provides a lens through which you understand a candidate's skills. You're not trying to trick the candidate. You're trying to precisely measure their skills. You want that lens to be as clear as possible and unclouded. And so that's what we strive to do here with the Dulosky. Let's go ahead and go to the next slide where you can see the question that's posed as well as the response options that are available to the candidate. You can see here, the candidate's asked to select one or more correct answers and essentially reminded any incorrect selections will result in your earning no credit for this question. So you can see what should be included in a differential diagnosis. And you'll see some options marked out in X. If the candidate shows any of those would be clinical judgment errors. They get no credit for the question. If the candidate shows cyst or benign tumor or odontogenic inflammatory condition, they would get partial credit for each of those responses, half a point basically. And then there's a few options there. I see reactive lesion, et cetera, that are not scored. So candidate could mark that and it would not affect their performance on the question. 150 questions on the exam that are like this. You know, I think as Dr. Sanders and Dr. Karsten have indicated, a very challenging, difficult examination that really requires intense critical thinking to be able to respond correctly.
And I took that exam too, the first one, and it was tough.
Next slide, please. And so as we were working with the process and thinking about, we wanted to create questions, scenarios to mirror what was occurring in dental practice as closely as possible. And so when we look at areas like restorative or prosthodontics, the need to develop three-dimensional models, very lifelike three-dimensional models that candidates could use to interact with, pan, zoom, manipulate, so that they could arrive at a proper diagnosis and determine an appropriate course of treatment and those kinds of things. So this is a still image before you. Unfortunately, I can't, given the WebEx limitations here, I can't really show you the actual 3D model here, but this is actually an earlier version of it. We continually improve it, but this is, I think, still pretty close to where we landed in the final. Next slide, please. We'll give you another view of this three-dimensional model. I'm hoping that comes through with compressed internet connections or what have you. That looks good on your screens as well.
Yeah,
next.
It's very easily manipulated, rotated, so that they can see it in a very clinical way.
And we provide a tutorial online as well, so that before candidates enter a testing session, they've got an opportunity to work with a 3D model and see how it operates so that it's not new to them when they get to the testing center. Next slide, please. And so a core question, so the Dulosky does not include a specific measure of hand skills here. And obviously hand skills are critical to the practice of dentistry. why did the Joint Commission, why did the Dulosky Steering Committee choose to go the route that it did? And really, this required some very careful consideration by the Dulosky Steering Committee as to whether to include that psychomotor component or not. And so a key factor in that was what evidence is there available that supports the utilization of, for example, for current licensure examinations that include both patient-based and mannequin components. What does that evidence look like? Does it support that measurement? And the committee noted the lack of research evidence that supported single encounter patient procedure-based examinations and mannequin examinations. Next slide, please.
We did try some remarkable simulators, though.
Yes.
It was kind of interesting.
I saw that we had a whole day there with the committee looking at the simulators that
Right.
brought in special for the committee to be able to look at. This next quote here. So we looked at the research evidence, the peer-reviewed research evidence that's available really publicly on existing clinical licensure examinations. And it was interesting. This was a conclusion that we saw from Dr. Stephen Friedrichsen, who is the dean of the Western University of Health Sciences out in California. This was the conclusion he reached in reviewing that literature. There is no peer-reviewed scientific evidence that correlates clinical licensure examination outcomes with other validated assessments of clinical competence. The process yields no verifiable value in its ultimate objective of providing for the protection of the public. So this was the same conclusion that the members of the Dulosky Steering Committee also reached in reviewing that research that was available when we talk about a rationale for not including the available techniques for hand scale measurement. Next slide, please. Now, present that slide and there's always a reaction in a way to that information. Those who are in the dental examining communities, disbelief, that can't be. I've seen with my own eyes, this was mentioned at the beginning, some of the mistakes that candidates have made. Our exam and the true, genuine belief that our exam protects the public. On the other hand, when you look at the reaction from those in the dental education community, those students that Dr. Karsten was mentioning, and the faculty, essentially, we've been saying this for decades that those exams lack validity, but little has changed. From our perspective, some of the best students fail these examinations while weaker students pass. Failures appear to be random.
One of the things I've noticed at OHSU is all our best students are taking the OSCE.
Yeah.
We had 40 take it this last time, one failed. Not sure what happened.
And I think, in past presentations, I've also given presentations with Dr. Michael Kanellis, who's a pediatric dentist from, who's also a member of the Dulosky Steering Committee, University of Iowa. And, he talks about years and years and years of data in working with the REB. And essentially, he can't predict which of his students will fail. But, there's always going to be a percentage that fail on that first administration. And what he was communicating is that without any remediation at all on the next administration, pass, 100% pass. And he showed slides with that data on the screen for years and years and years. Failures on the first administration, a certain percentage, and then no remediation and passing on the next attempt. And essentially, it just delayed those individuals' careers. From a psychometrician standpoint, from our perspective, it's not surprising. Exams that involve patients often ignore some fundamental principles of measurement. There's quite a bit of random error involved, and that's what we think is happening with those exams. Next slide, please. So how can these different perspectives be reconciled? I believe that examiners who are examining for these different agencies, they genuine feelings, that. And in those circumstances, it's definitely the case that they can see cases of poor performance, but those cases can almost always be attributed to poor clinical judgment. The candidate who submits their performance to an examiner believes that they are submitting something that is acceptable. if they didn't, and they're doing so because they don't have the clinical judgment to recognize that that it didn't meet the required criteria. The examiner is looking at it and using their clinical judgment. Clinical judgment is interwoven throughout. And so the importance, and the Dolosky measures that clinical judgment and does so objectively, fairly, accurately, with rigor, with validity. So, and again, I think here with existing clinical exams, a core issue concerns how those exams are administered and scored and how candidate performance is interpreted. And if you think about what examinations do for boards, the core task here in measurement is to essentially provide information and accurately estimate the level of a candidate's knowledge and skills based on a sample of their behavior, for example, performance on a restorative procedure. So next slide, please. So if you think about what's actually happening in a clinical licensure examination, you've got a candidate working with a patient, but every patient is going to be different. Different dental history, different underlying health conditions, a lesion that they may have. Every lesion is different. So the level of skills, therefore, that's required to treat a given carious lesion is going to vary based on those patient factors, as well as the features and characteristics of the lesion. If you think about the task that's presented before the candidate, essentially a candidate is asked to perform a specific task. And here's an example: perform a posterior amalgam restoration. There's grading criteria that they're made aware of. Remove all carious tooth structure, and then there is what did the candidate do? What was their achieved outcome? And here it's an example is that the caries remain in the preparation. The grading of the candidate's performance does not adequately consider the level of difficulty that's posed by the patient and their condition. It's ambivalent towards that. And so by not taking into account the level of difficulty that the candidate encountered, or that the patient posed, their condition posed, you're not able to get a performance rating that will accurately reflect the candidate's skill given those factors. And again, that last bullet point, that's the fundamental task of measurement. So random error and those kinds of things creep in. I talked a lot there. I don't know if Dr. Karsten or Dr. Sanders wants to.
Well, I must say that my history of many years of grading boards is what the student wants to find is a tooth that has a pinpoint lesion that qualifies. They don't want to present anything where they have to demonstrate sophisticated operative technique and excavate caries and design preparations. And I think in many ways that sort of compromises the whole purpose of the examination to have.
Agreed.
Yeah, I think one of my biggest concerns is that when they engage in these live patient exams, and I know more than one person that's got many years doing reb or NERB, that patient harm happens. And it's regrettable, and yet they make that part of a licensure exam. I think that's even more regrettable.
Yep. So if we could go to the next slide, please. So why do existing measures of hand skills fail to protect the public? A lot of it has to do with the lack of standardization that occurs when patients are involved. Given that every patient and their condition is different, essentially the bar that each candidate has to pass is going to be different for all candidates. And in fact, candidates can choose the bar through their choice of the patient, as Dr. Sanders indicated, just going for that pinpoint lesion as opposed to something that might be a little bit more complicated. There's additional issues in terms of the limited behavioral sample that you're looking at. It's not as comprehensive, not as reliable. Small number of patients involved, just 2 or 3, as opposed to over 100 patients that can be in the Dolosky. Small number of procedures that are performed. There also can be differences and disagreement on performance standards and what a correct answer is. So, for example, students can be taught in dental school that it's okay to leave a small amount of caries present and it would permit essentially remineralization. But in contrast, in current clinical licensure exams, you may be required to remove all caries, not leaving anything. Differences in, I can see Dr. Karsten wants to say something. I'll let you go.
I think an added consideration too for people that are concerned is that I know at least at OHSU, and I know from my friends at the University of Washington, that we take the accreditation standards very, very seriously. And we take those CODA standards very, very seriously, that it's not unusual for us not to graduate somebody for at least several months, even though they may pass one of these clinical examinations, because we believe they aren't ready. And we're not going to graduate someone that's not ready, that's not safe, at least as evidenced by what we've seen over those 4 years.
So additional note here, drilling on plastic teeth essentially shows that you can drill on plastic teeth. That's something we've heard from subject matter experts on many occasions. And as I indicated earlier, most candidates will pass on that second administration with little to no remediation in between attempts. Next slide, please.
That's what happened with the Reb a couple of weeks ago at OHSU. They kept me off my clinical floor as they did the remediation, and they all passed.
Yep. So in looking at evidence that supports use of an examination, what you look for from a psychometric perspective, you want to know that what you say you're measuring, you're in fact measuring those things. So how do you go about doing that? It's through something that's referred to as convergent validity evidence. So when you look at the relationship of performance on your measure, does it correlate with other similar measures? That would provide convergent validity evidence. And if it doesn't correlate properly, that's when you question an exam's convergent validity evidence. Next slide, please. So apologies in advance. So this is a little bit psychometrician or statistician 101 a little bit here.
You get to be a little geeky, Dave.
Let me get my pocket protector out.
Okay.
So a brief note on correlations, because we're looking at the relationship between performance on exams, for example. And so correlations can range between -1 and +1, with a positive correlation indicating that higher performance, for example, on the Dolosky correlates with higher performance in the dental clinic, for example. And so higher, they both are positive, though, as higher goes to one, higher goes to the other. With a negative correlation, you might see that higher scores on an exam might lead to poorer performance in the dental clinic. Obviously, that is not what you want. Another case here is essentially no relationship. Flip a coin. A correlation of 0, that's what that is. And it doesn't really matter. The two exams don't correspond at all. And so correlations, again, ranging between -1 and +1. The closer you get to the ones, either positive or negative, that's a perfect relationship. The closer you approach 0, that's no relationship. So next slide, please. And so what I'm about to share with you is some of what we saw when we looked at that evidence that was available in the peer-reviewed research literature. And so what you're going to see here is exams, and in this case, we've got REB and NERB, which of course NERB is the predecessor to CDCA. There's going to be overall and specific scales from the REB and the NERB, and looking at dental clinical outcomes, including and outcomes such as dental school GPA, faculty ratings of competence, test case simulations for clinical disciplines, grades in specific courses, for example, operative and fixed and removable prosthetics, competencies in restorative and pros and perio, simulated patients. So in these upcoming slides, that gives you a general overview of what's covered here. So here, for example, study by Gadbury, Amiot et al. On 2014, and this is REB and dental school GPA, correlation of -0.08. Next, amalgam restoration score, -0.01 with GPA. Composite restoration score, 0.06. Another one, -0.06, 0.06. Next slide, please.
That's essentially random then.
Right.
Dave.
That's correct. We're hitting that, we're hovering around 0. Root planing and dental school GPA, 0.12. Now we have a 0.29, and that's getting better. 0.06, root planing and faculty ratings of student competence, 0.15, 0.02, 0.05, -0.02. 0.18, a little bit better there again. Next slide, please. Uh, 0.05, now we're into the NERB here. 0.05, negative 0.01, 0.03, 0.10, 0.15, 0.11, 0.11, hovering again, as Dr. Karsten was indicating, around 0. Next slide, please. Here's another 0.05, 0.11, 0.02. And now on the next table here, this is looking at the relationship, for example, with the REB and Part 1 and Part 2 of the Joint Commission's National Dental Examinations. Correlation between REB and Part 1, negative 0.05. Correlation between REB and Part 2, negative 0.25. Clearly, that's in the opposite direction for what you want. Next slide, please. So the 25 correlations that I've just presented on the preceding slides, they range from negative 0.25 to 0.29 with a median of 0.05. How, again, do psychometricians and researchers interpret correlations? This little chart here provides some additional guidance, and this is by Jacob Cohen. If you do a search for interpreting effect sizes, this is Jacob Cohen's work will be among the first things you'll see. And so here, a correlation of 0.10, again, hovering very close to 0, is regarded as a small relationship. And you saw that the correlations, that median correlation we just obtained is even less than that. Median correlations, 0.3, large correlations, 0.5. So again, this is why the Dulosky Steering Committee, when it looked at the information, concluded that the lack of research evidence to support the use of these examinations, supporting existing single encounter patient-based clinical examinations, including mannequin examinations. Next slide, please.
Dr. Waldschmidt, this is Karen Fisher, the executive officer, and I hate to interrupt, but we are going a little over time, so I was wondering if I can just give you like a 5-minute warning to wrap it up so that we'll have time for board members to ask questions and to have discussion. I would appreciate it.
Absolutely, and that's critical, so I will fly. We want to make sure that we address your questions. That's really why we're here. So rationale for not including hand skills. This was in the technical manual report as well that we share with you, page 11, I believe. So you've had access to this information there. But we find that really it's clinical judgment that are the cases that appear before boards predominantly. Next slide, please. So in the basis of all that information, the steering committee determined that the public would be far better served by an assessment of clinical judgment. Clinical judgment has a causal effect on patient outcomes and psychomotor behaviors. Next slide, please. Key facts regarding the Dulosky: 150 questions administered in under 7 hours. We've got 3 administration windows in 2021. Results are reported within 4 weeks of that window. During the pandemic, it's offered for a lower fee, really in recognition of the very challenging circumstances that students find themselves in now. Next slide, please. Acceptance by dental boards. So at present, there are 6 dental boards that accept the Dulosky. Some of the acceptance is full, some of the acceptance is partial. So for example, in Alaska and Iowa, that's a partial acceptance. They also, in those cases, require a mannequin, I believe, in addition to the Dulosky. In most of those states, I believe they have now adopted permanently with regard to utilization of the Dulosky after the pandemic. And so I think Iowa is still temporary. We're learning more about that one. Indiana, they're in the process of seeking permanent. They're adjusting their regs. Wish I could spend more time, but I've got a 5-minute limit here. Next. We said the 5 minutes starts from right now, correct, Dr. Fisher? Just kidding. Next slide, please. I'll cover this in a little bit. Technical report you've all seen. Next slide. So when we look at information about the Dulosky and the convergent validity evidence that supports utilization of the Dulosky, here you can see correlations with Part 1, biomedical skills, and correlation with Part 2, clinical skills, clinical cognitive skills, and 0.54. That's really about where we'd want to see them. Next slide. We looked at the relationship between performance on the Dulosky and performance in the dental clinic. And so here, a correlation, this is essentially performance in clinic courses throughout in 3rd year, and you can see the names of the clinical courses at the bottom of your screen. In a correlation of 0.37 with a full study sample, it's a sample of 40, but when you take, there was one individual who we feel was a talented talented within the school, but likely didn't study for the exam, thought that they could just pass walking in. It didn't quite work out that way. They scored pretty poorly. But you can see that when we removed that one individual from the sample, that correlation moved to a 0.57 with clinical outcomes. So if you consider Cohen's recommendations for interpreting effect sizes, that is beyond the large category. When you remove the effect of measurement error in the criterion, which essentially is the appropriate way from a psychometric perspective of viewing this relationship, every measure is going to have error in it, both what you're using to predict the test and also the performance outcome. And this essentially removes error from the performance outcome. And that's when you get the 0.7. The 0.7 is really the best indicator of the true relationship here. Next slide, and I'd be happy to entertain the questions on that when we get into Q&A. In terms of what happened when candidates attempted the exam, you can see here, for candidates who were educated by accredited dental programs, we had a first-time failure rate of 9.5%. For candidates who were educated by non-accredited dental programs, international candidates, for example, international training, a 57.1% failure rate. Again, that one, there's a smaller sample size there, just 14 individuals, but that's obviously a significantly higher failure rate. And then with a total failure rate there of 12.5%. Next slide, please. Feedback we've gotten from candidates has been extremely positive. They found it to be an extremely challenging exam, but and that's a good thing, I think. They've also provided some feedback to us that we've taken and further improved the exam. So we are always looking to continue to improve our work. Next slide, please. So when you think about exams that can be selected and used to protect the public, certainly this is a newer exam, but we have strong evidence available. Oh, there's one more study that I want to share real quick, and that is we asked an academic, we asked an individual to rate the top 20% and the bottom 20% of their dental class in terms of their clinical skills to indicate their performance. And we looked at the top 20% and bottom 20% and compared their performance on the Dulosky. And when you look at that information, it was a 1.28 standard deviation unit between performance in that top 20% category and that bottom 20% category. And I realized 1.28 standard deviation unit difference. What does that mean? And I've been asking my staff, please give me some practical examples of what a 1.28 standard deviation unit difference, what that kind of compares to. And one of the things that was shared was it's the difference between having, for example, a Pro Bowl quarterback or not. And I can tell you, being from the Chicago area with Mitch Trubisky, who was not a Pro Bowl quarterback, comparing that with Patrick Mahomes and all those, Tom Brady and others, big difference in performance. Also, the difference in average daily high temperatures in Chicago, if you're in Chicago, the difference in average daily high temperatures between April and December. So a very large and huge a difference there between that. So this slide, again, showing you how the different examinations play out in terms of protection of the public and the evidence that's available, what occurs in the use of the exam and the potential for patient harm and those kinds of things, the candidate's ability to choose the object of evaluation and influence the level of skill they need to demonstrate to be licensed, gives you an overview. And you can see, I think, he really compares quite favorably in that regard. Next slide, please. So there's additional resources available here. Of course, you all have access to the slides, and so you'll be able to take a look at this as well. Next slide, please. Was I close to the 5 minutes? I did my best.
Okay, this is Dr. Morrow. Thank you very much, gentlemen. A wealth of information and materials to give us a lot to think about. I know during the course of your presentation, there were not any questions or comments. Do any members of the committee have any questions or comments they would like to make to our guests, to provide to our guests before we say goodbye to them? So if you do, would you please use your raised hand feature?
Dr. Morrow?
Yes.
This is Dr. Letting. I can't raise my hand for some reason, but I do have some questions.
Sure, go ahead.
Oh, thank you for being here today and giving us this presentation. It's very interesting. I wanted to know if does CODA have a minimal clinical requirements? I mean, as far as like ground preparations, bridges, do they have a minimum that the students have to perform in school by the time they graduate?
No, I will comment on that. They do not. They have a requirement that the school demonstrates that they have assessed the student's capability in performing those tasks, but they do not set specific measures that they must accomplish. They just have the schools have the requirement of showing that they've measured the student's capability to perform.
It's competency based.
And it's my understanding as well, and this is one of the things that the Lasky Steering Committee considered, on average, 400 to 500 evaluations across the dental student's career are occurring for evaluation.
Yes, because I've had the opportunity to interview students over the years, and I've asked them about their requirements. And just recently, somebody told me that they only had to do one crown the whole school in all the four years they were in school. And then in other schools, they require quite a few crowns. So it's interesting, that they would be able to graduate just with only one crown being prepared, and this concerns me about not having a clinical exam for the board. I also have some other questions. I wanted to ask you, last night I had the opportunity to go on the ADA website and I looked at the exams. I went to the test. I looked at the tests that you have on the exams of both the Jaloski and the Integrated Dental Board exam, and they look very, very similar. I just wonder how different are each of these, and how are you applying these? What do they differ? But also, I wanted to ask you if, when you take this exam, are the X-rays and the pictures, can you zoom on the X-rays and pictures that are on the exam? I know I could do it on my computer, but I don't know whether students are able, if the students are able to do it at the exam site. But I wanted to know the difference between the two exams, because they look very similar, and also about them being able to look at the X-rays.
I can tell you they're profoundly different in the way the instructions are posed and how it plays out. So an OSCE question is not a multiple choice question, not the ones that you're familiar with. Would you say that's that's about right, Dave?
Absolutely, and I'm right. I'm just calling up some slides. I've got to this very point, this very question, actually. So the INBD is designed to measure cognitive skills for a candidate. Certainly, in terms of comprehensiveness of the dental domain, there's overlap in some of the content areas that are assessed, but this is a much deeper dive, a much more deeper understanding of an individual's clinical skills that are assessed here. So the Jaloski is focused on the clinical tasks a dentist performs again while providing direct chairside treatment. It deals with microjudgments, with errors, with whether the student recognizes that they have met certain success criteria. Whereas the Jaloski, again, with its focus on cognitive skills, there you're dealing with the biomedical and behavioral underpinnings of clinical decisions knowledge. It's more about the why aspects. Practice and profession considerations can also be included, whether you're a good consumer of evidence-based dentistry. An example would be in the Jaloski, you might be asked to review patient information and write a prescription. Whereas in the INBDE, it's going to be, do you understand basic principles of pharmacokinetics and pharmacodynamics for major classes of drugs and other over-the-counter products to guide safe and effective treatment? In the Jaloski, identify the final needle position, the point of insertion, angulation, and depth immediately prior to an injection to essentially provide anesthesia, local anesthesia for a given procedure. For the INBDE, would be about understanding local and central mechanisms of pain modulation. It can be on the Jaloski side, identify flaws in a metal ceramic restoration. On the INBDE side, it's understanding dental material properties, biocompatibility, and performance. So there is very much a distinction between the practical applied aspects of the Jaloski as it's focused on providing direct chairside treatment to patients.
So I just walked our faculty through building a special needs OSCE. And they had to struggle with how do you construct these questions. And it took a lot of mentoring on my part to get us to that point where we could build actual OSCE questions.
Okay, thank you very much. Dr. Laren?
Yeah, I do have some other questions. Are you able to zoom in on the X-rays and the?
I would say when we're talking about clinical photographs, that is not a capability at present. It's with the 3D models they do, and so we make sure the Joint Commission has convened an ad hoc image quality committee that formed a specific committee on image quality. So when we make sure that when radiographs and clinical photographs appear on the screen, that they are of a sufficient size that a candidate can, they're of diagnostic quality essentially, that the candidate can reach a conclusion on the condition of the patient.
They were large in the exam I took, Dave, and still similarly large.
Yes.
Yeah.
Okay. Well, and also the X-rays. I assume that you cannot zoom in on them.
That's correct.
They're big though.
Yeah.
Okay. And I have another question. I still have 2 more questions, please. Okay. So the people that formulated this exam, that developed it, did any of them have experience in the clinical exams, like working for examinations companies like REB or NERB? Do they have experience in looking at the clinical exams that are out there right now? Like yourself, have any of you?
I mean, I think you can see that there are members of the Joint Commission, for example, Dr. Sanders, who has background and experience in those. I think if you consider the individuals involved, many of them probably would have had prior experience, but we are operating in the same space. So we wouldn't have wanted to include current examiners because essentially they're offering a product that essentially competes with our product, really. So, but certainly the individuals who are involved have very, very strong clinical examination experience, and that's what led to their selection to work as test constructors.
Yeah, it would be good to have somebody that's, on the committee that could at least have an evaluation from I don't know if you evaluated or you surveyed examiners, clinical examiners, to see what they thought about removing the clinical exam. But also, I have my last observation that I saw here is about, I just wonder why you differentiated the accredited and non-accredited candidates that passed or didn't pass, because that's not a fair comparison at all. If you look at the numbers, you shouldn't even be on here. I'm a foreign dental graduate, and this is actually, to all due respect, it's a little offensive and could be discriminatory. So if you had a fair comparison, I see that it's fine. Like, if you selected, for example, you just said 14 non-accredited and 231 accredited. If you had 14 and 14, if you did a random selection of 14 of the accredited and compared them to the non-accredited, that's fine. But if you're doing a comparison like that, that's not fair. I wouldn't even put this on here because it doesn't look like, this is not, it shouldn't be on here.
And I guess to your concern, I think we kind of worked through those slides, but I think if you look at the technical manual, you'll see we've added a footnote and a caution around interpretation of that, because it is a small number. This is just information that has been requested throughout the years with the Joint Commission. There's always a request and how the exam specifically performs on individuals from each of those communities, in particular with a focus in the U.S. on individuals who are trained, because typically that's a requirement, to be licensed, trained by CODA accredited dental program. So that's why that information is presented the way it is. But certainly I can share that information with the members of the Joint Commission, and it can be discussed regarding reporting those things.
Yeah, I would appreciate that. But also it doesn't reflect on the protection of the public. The disciplinary cases that we have do not reflect that difference, that same comparison. I would say it's, many more from CODA could approve schools. So I would be very careful when you mention that.
Sure. And I would say that in building the content of the examination, we've really done everything we can to make sure that we are fairly and accurately measuring. And that's why, I share that information in the background about the build of the patient box. I think if you look at other examinations that are currently out there, many of them in the medical field, for example, many of them can be heavily loaded with language, paragraphs of information. And our exams are very concise.
Thank
Correct.
you.
To help with.
Thank you very much. I think we need to move on to any other committee members that have any comments or questions. Are there any other committee members that have any comments or questions of our guests before we dismiss them? Please use the raised hand figure. Okay, not seeing any. Doctors Sanders, Carson, and Waldschmidt, we appreciate your expertise and your time spending with us, and we hope that we will be able to communicate with you in the future with more information and more details regarding the Dulosky examination. So thank you very much, and I hope you have a great evening.
Thank you so much for this opportunity.
Thank you.
You're
Appreciate
welcome.
it. Thank you.
Good weekend.
With that said, is there any other discussion that the committee members would like to proceed with at this time? Please use the raise hand feature if you have any comments or questions for the committee. I don't see any. Staff, do you see any on your screens?
Yes, Dr. Felsenfeld has his hand raised.
I'm sorry. Good. Dr. Felsenfeld.
No problem, Dr. Morrow. Thank you. I spent a lot of time reading through the presentation. I know this was long and got interactive for these guys. It was a little hard to follow it 100%, but the reality is my personal history has been, I have been very experienced, if you will, in the development of standard examinations at many different levels, certainly on the oral surgery side for the board and for their dance committee right now. I've been doing this for years. I was also very involved, as you know, Dr. Morrow, in the very development of the portfolio exam, which was one step in the direction of trying to eliminate freestanding human subject examinations after school, a one-shot assessment of how good someone is or isn't, whether they pass it that day or not, for whatever reasons. We have in our schools lots of formative assessments, and I think they use the word 350. I don't know the answer to that, but there's certainly tons of stage checks that have to be going through by all of the students. And then they have a summative one at the end where they take their final competency exams, and that's how schools go today. They have to be competency based, not by numbers. And I think if you also look at the disciplinary actions that we have, if you eliminate the ones that are criminal or drug related and things like that, most of them are judgment. The people are capable of cutting a crown or doing some perio surgery or whatever it is, but they have very poor judgments. And what this exam looks at is judgment. It looks at putting it all together and what can you do for a patient. And it doesn't really matter whether you can cut a crown that day or not, because that's what happens. Sometimes on a given day, you may have a bad day. Certainly, we understand that. So it is, to me, an excellent example of what we can do in a non-patient-based exam. And I think that the key word in the Dulosky is the word objective. It's not relying on one or two people to look at something and say, I don't think I like that so well, even with whatever the standards are, because they are variable. So I think this is an excellent example of where we are trying to go as a board. If you look at where we've been and where we're going right now, we are trying very hard to keep the health of the public safe by not having patient-based exams. Even the mannequin-based exams are, potentially have problems, and it's just an extra step that really doesn't change anything. And if you look at it, and I think at some point I'd like to see if we have all these disciplinary actions, how many of them came from what level of licensure? I think this is good. I would like to move that we pass the report on and have the full board consider using the ADA Dulosky as a pathway to licensure.
Okay. We've had a motion presented by Dr. Felsenfeld to recommend that the full board consider the ADA Dulosky as a pathway to licensure. Do I have a second? Please use the raised hand feature. We have Thomas Stewart. Tom? Dr. Stewart, did you second?
All right, yes, second that. Thank you.
Okay, thank you. Okay, the motion has been made to, and seconded, to recommend to the full board, consider the ADA Deloski as a pathway to licensure. At this point, I would ask moderator to activate, facilitate public comment.
This is the moderator. We have opened up the Q&A panel on WebEx. If you would like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to the host. Our first comment comes from Kimber Cobb. Kimber, your line is open. You will have 2 minutes.
Thank you. This is Kimber Cobb with Commission on Dental Competency Assessments, CDCA. And I would just like to suggest, with all the information presented this evening, this is definitely a weighty decision that is before this committee and the board. And I would like to suggest that the board, or before this decision is made, to refer to the board, that CDCA be allowed to present some additional information regarding the current clinical licensure exams that are present in our profession before this decision is sent forward to the bigger Board of Dentistry. Thank you.
And seeing no additional requests for comment, would you like me to close the panel?
Yes, please. Thank you. Okay. The motion, again, I will repeat the motion. The motion is to recommend that the full board consider the ADA Deloski examination as licensure in California. I ask the staff, would you call the roll to record the vote?
Thank you. I will now call the roll and record the votes for this agenda item. Rosenfeld?
Aye.
Rosenfeld, aye. Laren?
Laren, aye.
Laren, aye. Molina?
Molina, aye.
Molina, aye. Morrow?
Morrow, aye.
Morrow, aye. Olagi?
Olagi, aye.
Olagi, aye. Stewart?
Stewart, aye.
Stewart, aye. And the motion passed.
Thank you very much. And I want to again give our thanks to our guests, Dr. Sanders, Karsten, and Waldschmidt. And are there any committee member comments for future agenda items to be placed for future examination committee meetings? If so, please use the raise hand feature. Seeing none, are there any public comments? DCA moderator, would you please facilitate the lines for public comment?
This is the moderator. I've opened the Q&A panel. If you'd like to make a comment on future agenda items, please click on the Q&A icon on the screen. Type "I would like to make a comment" into the text field and submit that to the host. And seeing no requests, would you like me to close the panel?
Yes, please. Okay, thank you very much. This concludes the Dental Board's May 13, 2021 Examination Committee meeting. This meeting is adjourned. Moderator, will you please promote all other board members back into the panelist list?
I will do so.
Thank you.
All members have been promoted. Do need to let you know that it looks like we did lose Dr. Stephen Chan.
Thank you, moderator. As we try to get Dr. Chan back on, it looks like Ms. Burton has her hand raised. She might want to do a mic check because I think she's connected now, and staff has asked for a 15-minute break. So while we're trying to get things sorted through, if we could take a 15-minute break and reconvene at 4:15.
We will now reconvene the open meeting of the full board. We will begin with agenda item 8, budget report. I will ask Steve Long, the board's budget analyst, to present this agenda item.
Thank you, President Pacheco. Good afternoon. My name is Steve Long, and I'm the budget and contract analyst for the board. I would like to make a note that corrections were made to the budget report since the agenda item was originally posted. The revised budget report was provided to board members as well as posted to the board's website. The items that were corrected are now highlighted in yellow, and I will be presenting on the revised report today, which is titled Amended Agenda Item 8, Budget Report. So starting on page 1, the first section of the report is a summary of expenditures for the first 8 months of the current fiscal year from July 1st, 2020 through February 28th, 2021. The state dentistry funds appropriation is consistent with the governor's budget released in January 2021. The board has a current year appropriation of approximately $17.7 million and has spent roughly $10 million or 56% of its total appropriation during this time period. Of that amount, approximately $5.1 million of the expenditures were for personnel services and $4.9 million were for operating expenses and equipment. Attachment 1, which is on page 2, displays a detailed breakdown of expenditures for the state dentistry fund by line item. The prior year budget and prior year actual expenditures are displayed in the green columns. The current year budget and the year-to-date expenditures are displayed in the blue columns. And the expense projections for year-end spending and the remaining balance are displayed in the orange columns. The board is projected to revert approximately $2.5 million at the end of this year, and this is reflected at the bottom right of the chart. Attachment 1A, which is on page 3, displays an analysis of the state dentistry funds condition based on the governor's budget. The board has sufficient funds in reserve for economic uncertainties and has historically reverted a significant amount of money at the end of each year. Attachment 2 on page 4 displays an analysis of the state dental assistant funds condition based on the governor's budget. This fund merged with the state dentistry fund on July 1st, 2020. The reserve balance is kept in the dental assistant fund for a period of time after the merge to be able to pay any expenses from previous years. After a period of 2 to 3 years after the merge, the reserve balance will be transferred to the state dentistry fund and the state dental assistant fund will be abolished. And finally, the May revise is expected to be released by the governor in the next couple of days. This version of the budget includes changes to the governor's proposed budget from January and is based on the latest economic forecast. Board staff will review new versions of the budget as they are released and will bring that information to the board meeting in August. There is no action requested at this time, and this concludes my report. Thank you.
Thank you, Mr. Long. Are there any board member comments? Please use the raise hand feature. Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We have opened the Q&A panel. If you'd like to make a comment on this item, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text box and submit that to the host. And seeing no requests, would you like me to close the panel?
Yes, thank you. We will now move on to agenda item 9, discussion and possible action on board policy and procedure manual. I will ask Vice President of the Board, Ms. Rosalinda Olagi, and Executive Officer Karen Fisher to present this agenda item.
Thank you, President Pacheco. Board Policy and Procedure Manual was last reviewed in 2016. Staff, along with legal counsel, reviewed the Administrative Policy Procedure Manual and have proposed revisions for the board to consider. Strikeouts indicate deletion and underline indicates addition. Most of the recommendation changes are considered non-substantive. Please note, board members, agenda item number 9 did receive modifications. Board members, interested parties, and stakeholders received the amended agenda item material via email, and it was posted on the board's website for reference. We will now proceed to review the revised Administrative Policy and Procedure Manual page by page. Board members, please use the raise hand feature to make comments as we review together. Starting on the cover page, we will look at cover page along with table of contents, which is page 1 and page 2. Board members, I will ask to use.
Ms. Olagi, I'm sorry to interrupt. This is Karen Fisher. I think that we don't have to review the cover page or the table of contents because the table of contents will likely shift. So we can probably jump right to page 3.
Perfect, thank you. And we'll take a look at page 3, which is titled Chapter 1 Introduction, and page 4 together. We'll take a moment to pause for board members to review. Please use the raise hand feature if there are any comments. Seeing none.
Ms. Olagi, it
Yes.
appears Dr.
Oh,
Morrow
sorry.
has his hand raised.
Thank you. Dr. Morrow?
Yes, thank you. Under Chapter 1 Introduction, which is page 3 of the document, page 29 of 433, second paragraph identifies that Business and Profession Code 1601 and 1603 states that the board consists of 8 dentists appointed by the governor, 1 who must be a member of the faculty of any California dental college. But in addition, also, Professions Code, BPC Code 1602 states that only 1 of the dentist members can be a faculty member. I think that limitation of only 1 has been overlooked in the Policies and Procedures Manual, and this I think is something that we should consider adding to it to identify that 1 must be, but only 1 can be, according to Business and Professions Code 1602.
Thank you, Dr. Morrow. Ms.
Another
Fisher.
comment on that thing.
Go ahead, Dr. Morrow. My apologies.
That's okay. Another comment on that same page, second paragraph towards the bottom, the last 2 lines of the second paragraph. Board members serve without a salary but are compensated $100 per day. If you look at the salary or the term salary is identified at least 5-6 times further on into the document, where I think that if the compensation, and it says they're without salary but for compensation, I think that wherever in the document it refers to board members' salary, that word term salary should be corrected to compensated.
Thank you, Dr. Morrow. Ms. Fisher? For all the comments that are being taken, is it recommended that we take each of the comments and then at the end, if a motion is made, to make that motion with the revised comments that have been taken from board members?
I'm going to ask Ms. Welch to jump in on that question. I think that that would work. And Dr. Morrow, if you would lower your hand. So
This is Tara Welch.
Thank you.
Yeah, board counsel. Yeah, I think that's a good idea. I think that as long as the revisions are non-substantive, we can just, add them as people make the suggestion, or someone can counterpoint whether or not to add or revise the language. If it's substantive, we just want to make sure that we have a conversation about it before we just automatically add it. My point is just that if members have comments like Dr. Morrow's to add certain things, all of the things that he just talked about are statutory and or minor modifications, so we could just continue to move through this manual, noting that we're going to go ahead and add his corrections. And then if there's something substantive or objectionable, then we can have a discussion about whether or not to add that or not.
Wonderful.
And then at the end, we could just approve the whole thing.
Okay, wonderful. Ms. Fisher, do we have a staff member taking track of the comments that are coming from board members if a recap is needed at the end?
We do. We have a number of them. And just to let you know, Ms. Burton also has her hand raised.
Okay, thank you. Ms. Burton?
This may be moot given your last comment, but I wanted to ask Dr. Morrow the reference to only one person who is a faculty member. That's in 1602. You said?
That's correct, Ms. Burton. It's in Business Information Code 1602.
Okay, so then we would want to add 1602 to that, to the code sections we referenced.
That's correct, and that's how staff has recorded it.
Okay, thank you.
And Ms. Burton, if you could, thank you, lower your hand. I think you've got the hang of it now.
Thank you, Ms. Burton, and thank you, Dr. Morrow. Are there any additional, before moving on from pages 3 and 4, comments from board members? Seeing no hands, seeing no hands, we will now move to pages to page 5. Seeing no raised hands. Moving along to page 6.
This is the
Dr. Chan.
Dr. Chan has his hand raised.
Okay, Dr. Chan?
A little lapse in the connections. Can we go back to page 5? It's page 31 of 433.
Absolutely.
Okay, board members, just to clarify, we're using the copy that was sent to you, so you can go ahead and refer to the numbers in that document. The total page number that was in your meeting materials no longer really applies.
Okay.
So I think you want to be on page 5. Is that correct, Dr. Chan?
That's correct. That's correct.
Go ahead.
So the item is on board council committee member attendance at board meetings. Are you there?
Yes.
Go ahead.
Okay. So this is kind of a comment, and it has to do with maybe itemizing what this means. When I was interviewed for this second reappointment, that it was interesting how one of the interviewers framed the question. She said, "Do you have any problems in attending board meetings?" And I didn't understand what that meant. She said, "You missed a couple of meetings." I said, "I don't think I missed any meetings." But then I had to look back, and one of the one of the later times when we had a conference call scheduled, and we had the notice, and it was because of some timetable that we had to meet. And I think we had the 10-day notice, but in the notice, it says that because of Bagley Keene, we have to have it in a public area where the public could comment. So I tried to go to our public library to see if I could arrange to have it there, but didn't have enough time because the decision makers weren't going to be there for another week. So I couldn't make that one. The second one that I found that I missed, and I didn't miss it because I talked to the attorney ahead of time, was a disciplinary action that had to meet a certain timetable. And it turns out that I declared that I had a conflict of interest because the spouse of the person in the disciplinary action actually practices in my town. So I did talk to the attorney, and I think I talked to Karen on this and say, I have a conflict of interest and I don't think I should participate in this one. So, but it was the way that the missing meetings were not fully disclosed why it was missed. And that's the comment on that.
Thank you, Dr. Chan. In hearing that, Dr. Chan, are we looking, when we're getting more specific, because it says members shall attend all meetings, are we looking for language that may separate an in-person meeting versus a virtual meeting or a conference call meeting?
I'm uncertain. I'm uncertain on this because with the Bagley Keene, having things in a public arena can be problematic. And then I think the second one was because of maybe not whoever the interviewer was didn't have complete documentation on why the meeting wasn't attended. I had a conflict of interest, and I checked before I excused myself from that.
Okay,
So
thank
it
you.
may have been whatever the reasoning was behind it didn't get to the, it wasn't the appointment secretary, it was someone else in one of the interviews.
Thank you, Dr. Chan, for your comments. This is Karen. I think that you had a unique situation. Board members can miss meetings. Obviously, there are circumstances that come up. I think the moral to the story is just for board members to be aware of when they do miss a meeting so that if they go to an interview in the governor's office, they can explain why they missed the meeting.
Exactly. Thank you, Karen.
Uh-huh. Ms. Pacheco, Ms. Olagi, please feel free to move on.
Thank you. Moving to page 6 of the manual for comments, board members. Seeing no raised hands, we will move to page 7. Seeing no raised hands, we will now move to page 8. Seeing no raised hands, we will now move to page 9. Seeing no raised hands, we'll move to page 10.
Just for clarification, so we're on page 10 and it's chapter 3. Is that correct? Is everybody on the
Yes.
same page? Okay. And Dr. Morrow, did I hear you had a question?
Yes. Well, this is one of the pages where the term salary is used twice, and on this page, and also 1, 2, 3, 4 times on page 11, with one being with a strike through.
Thank you, Dr. Morrow. We'll do a word search when we finalize this, and we'll make that change.
Great. Thank you.
Looking at page 10, titled Chapter 3. Seeing no hands, we will move to page 11. Seeing no raised hands, we will now move to page 12, which is chapter title 4, chapter 4. Seeing no raised hands, we will move to page 13. Seeing no raised hands, we will move to page 14. Seeing no raised hands, page 15. Seeing no raised hands, page 16, titled Chapter 5. Seeing no raised hands, moving to page 17.
I just want to draw to the members' attention what we've added, which is a suggestion to put something in our policy and procedure manual about legal opinions from outside parties.
Seeing no raised hands, we'll move to page 18. Seeing no raised hands, page 19.
Ms. Olagi, I see that Fran Burton has her hand raised.
Thank you. Ms. Burton?
I want us to have some discussion, and I don't know where this fits, if it fits better under communications on page 16 and 17, but I have a concern about people speaking for the board. And I think that we need to have something in writing that makes it very clear that people can't speak for the board, particularly when it gives a perception that the board is supportive of something that it may or may not have discussed. And I don't know where that fits. I think it fits more under communications, but communications, that what's written there is more narrow. I'm just speaking in general that, and I think the way it starts is that the official spokesperson is the board president.
I'm
And
there
so
with
I
you.
think it,
And what is it that you wanted to change?
I want to add something that makes it very clear that no one speaks for the board. This, with the way this thing starts, it talks more about speaking requests. You follow me?
This is Tara Welch, Board Counsel. Can we take a look at page 16? Because I'm thinking, you know, if we add anything, or let's at least review communications with other organizations and individuals. Here, I think it makes clear that the board's president can designate speaking on behalf of the board, but otherwise the official spokesperson for the board is the board president. Does that work?
That is where Ms. Burton has been, and I think she feels that it needs to be emphasized a little more. But Ms. Burton, why don't you lower your hand? And we've got Dr. Laren who would also like to comment, and Ms. McKenzie who would like to comment. So maybe let's take those comments and see where they end up. Does that work for you, Ms. Olagi?
Yes, Dr. Laren, please.
Dr. Laren, you are muted. You'll need to unmute yourself,
Oh, sorry,
Dr. Laren.
Thank you.
Okay.
This is nothing to do with Fran Burton's comment, but I wanted to go to chapter 6, please, where we were.
Can we wait one? Yeah, Dr. Laren, can we hold on to that? And board members, can we finish with the communication section on page 16, please? And we'll come back to that, Dr. Laren. Ms. McKenzie?
Yeah, I was just going to maybe respond to Fran's comment. I don't know if this addresses it, but back under general rules of conduct, it says board members shall not speak or act for the board without proper authorization. So I thought that was what she was trying to get or was trying to make clear, and it does have that under it's the first rule under the general rules of conduct. So I don't know if that resolves her issue or not.
Thank you, Ms. McKenzie. We'll take a moment to review that area. And then...
No, it doesn't. My response is no, it doesn't. And if I need to be clearer, I have known over all my time on the board where groups and organizations will come to people that they know on the board or have some affiliation with, and there can be a perception that because they speak with certain people, that is an overall board, that whatever it is an overall board agreement, and it isn't. And so my point is that we all come to this with involvement in a lot of other organizations, but we need to be very clear. No one speaks to the board but the president, unless the president has designated someone else.
This is Tara Welch, Board Counsel. So we've got the board president speaks as the official spokesperson on page 16, and Ms. McKenzie was referring to the rules of conduct on page 4. Can we take a look at page 4? The first rule, board members shall not speak or act for the board without proper authorization. Perhaps there we could make a clarifying statement or change that first sentence a little bit.
Or do we want to, for emphasis, take that first rule and stick it in on page 16 under communication, just for emphasis? So in other words, we start the paragraph on 16 under communication with other organizations and individuals that the official spokesperson for the board is the board president. The president may designate the executive officer et al. To speak on behalf of the board. And then for additional emphasis, we could insert board members shall not speak or act for the board without proper authorization. Does that work, Ms. Thornton?
That would work.
So noted. Is there any further discussion on this change? Okay, seeing none, Ms. Olagi?
Thank you. Dr. Laren?
Yes, I wanted to go back to where it says Chapter 6 mandatory training.
I'm sorry, this is the moderator. Can you specify what page that was?
You know, I'm looking at the book, so it might have changed on the, because I couldn't find the other one that was downloaded. But it's Chapter 6, Other Policies and Procedures. That's what it says on the book.
So I think it starts on page 18 with the documents that the revised documents we sent out. That's where other policies, Chapter 6, Other Policies and Procedures start. Is that where you wanted to be, Dr. Laren?
Yes, yes.
Okay, why don't you lower your hand and go ahead with your comment? Dr. Laren, I'm sorry, you're muted.
Sorry. Where it says mandatory training, can you see where it says all these important areas, including ethics, conflict of interest laws, sexual harassment, board orientation? Okay, so on the next page, or a conflict of interest was scrapped out. So, and then it was placed on like a second or third page. It's out of order and it doesn't follow this paragraph where it says mandatory training. I think it'd just be better if you brought it over so it follows the wording on the first paragraph. I don't know if you understand what I'm saying, but
I do understand what you're saying. And Ms. Welch, you might want to step in here, but our note is that this is not a separate training requirement. Conflict of interest issues are covered under the board member orientation training described below.
And then maybe we should take it off where it says mandatory training.
That's what we're doing.
Or here on this page, it doesn't, on the paragraph, it says mandatory training, it's not scratched off. I can't see it on the, where's mandatory training? I just had it. There, it says conflict of interest laws right there, the second line at the end. Then it should be removed, I guess.
I guess I'm confused because on the
I
what
understand.
we're looking at, you understand?
Yeah. So in the paragraph, it says state law requires board members within DCA to complete training in several important areas, including ethics, conflict of interest laws. And she's saying we probably need to strike conflict of interest laws from this provision.
Paragraph.
Exactly.
Gotcha.
Exactly. Thank you.
And Ms. Olagi, oh, Meredith's hand went down. And Dr. Laren, can you put your hand down, please? Thank you. Okay,
Thank you.
staff, I believe, yeah, we've recorded everything so far. Ms. Olagi, you can proceed.
Okay, thank you. Moving to page 19. Seeing no hands, we will move to page 20. Seeing no hands, we will move to page 21. Seeing no hands, we'll move to page 22. Seeing one hand for page 22, Dr. Montel?
Hi, can you hear me?
Yes.
Great. I was just a little confused by number 1 on that page where you crossed out a lot of that sentence, but then to me the sentence didn't make any sense afterward. So I see the travel is in connection with a speech given by, and then everything's scratched out, and it continues the lodging and subsistence expenses are blah, blah, blah. So
actually, this is a Where's Waldo question. So if you look a little closer, member is actually in the middle there. If you look a little closer, because I'm joking to some degree because I had the same comment. I thought this doesn't make any sense, and then I looked a little closer. So now I think it makes sense. But you got the prize because you and I did the same thing.
All right, thanks so much. Appreciate it.
Thank you. And if you lower your hand, that'd be awesome. Thank you.
Moving to page 23. Seeing no hands. And that concludes the review of the policy and procedure manual. That was the last page of 23.
Thank you. Are there any other board member comments? Please use the raised hand feature. Seeing none, is there a motion and a second to approve the manual? Please use the raised hand feature. Dr. Loren?
Yes, I make a motion to approve.
And Ms. Burton.
Second.
Thank you. So the motion is to accept the revised manual with the suggestions noted. DCA moderator, please facilitate public comment.
This is the moderator. I've opened the Q&A panel. If you'd like to make a comment on this item, please click on the Q&A icon on your screen. Type I would like to make a comment into the text box and submit that to the host. And seeing no requests for comment, would you like me to close the panel?
Thank you. And now, Board Secretary, please call the roll and record votes for this agenda item.
The motion is to adopt the revised Administrative Policy and Procedure Manual as amended. Burton,
Burton, aye.
Burton, aye. Chan,
Chan, aye.
Chan, aye. Felsenfeld, aye. Loreen,
Marina,
Loreen, aye. Mackenzie,
Mackenzie, yes.
Mackenzie, yes. Medina,
Medina, aye.
Medina, aye. Mendoza, Mr. Mendoza? Was that an aye? Did someone hear an aye there? It's the reception here. Mendoza, can you hear me?
I was
Aye. Thanks.
I was force muted, but Mendoza, aye.
No problem. Mendoza, aye. Molina,
Molina, aye.
Molina, aye. Montel,
Montel, aye.
Montel, aye. Morrow, aye. Morrow, aye. Olagi,
Olagi, aye.
Olagi, aye. Pacheco,
Pacheco, aye.
Pacheco, aye. Stewart,
Stewart, yes.
Stewart, aye. And you,
Yes.
you, aye. It is unanimous. The motion is approved.
And thank you. That concludes the May 13th, 2021 Quarterly Dental Board meeting. This meeting is recessed until Friday, May 14th at 9 a.m. Thank you, and everyone have a good evening.
Good night.